Medical emergencies in the dental clinic. Introduction. An emergency is a medical condition demanding immediate treatment. Every dentist should have the basic knowledge to recognize, assess, and manage a potentially life threatening situation until the patient can be transported to a medical facility. Prevention of medical emergencies. Comprehensive medical history must be recorded for all the patients and must be updated regularly. An assessment should be made to judge patients with severe medical conditions so as to check suitability for undertaking dental treatment. Patients with severe or unstable medical conditions should be referred for treatment in medical hospital. Prevention of medical emergencies. The entire dental clinic staff must be prepared to assist in the recognition and management of any potential emergency situation. Dental clinic staff should know the basics of recording and evaluation vital statistics, APC of resuscitation, how to administer oxygen, and when and where inappropriate intramuscular and intravenous delivery of medicine are required. In order for the staff to be effective, get training, conduct mock drills, and practice regularly. Emergency equipment. The following equipment has to be carried and must be readily available in dental practices: oxygen cylinders and regulators suitable for delivering high flow of oxygen, syringes and needles for drawing and administering drugs, bag mask device with oxygen reservoir, basic airway adjuncts, equipment for recording blood pressure, spacer device to deliver salbutamol. The emergency equipment must be checked frequently to make sure it is operational. The indications and initial adult dosage of essential emergency drugs are listed below. The drugs include oxygen, epinephrine, nitroglycerin, antihistamine, salbutamol, aspirin. Additional emergency drugs are listed below. They are glucagon, atropine, ephedrine, hydrocortisone, morphine and nitrous oxide, lorazepam, and flumazenil. Management of medical emergencies. Vasovagal syncope, commonly called as fainting. It is easily the most common cause of sudden loss of consciousness, with up to 2% of patients fainting before or during dental treatment. The predisposing factors include pain, anxiety, fatigue, relative hypothermia, and fasting. Some of the signs and symptoms includes feeling of dizziness, cold and clammy skin, slow thready pulse, loss of consciousness with collapse if unsupported. Management. Lower the head to the level or below the heart, loosen clothing, monitor pulse, determine the precipitant and avoid in the future. If bradycardia persists with no evidence of recovery, to rapid full pulse, try tiny dose of atropine. Cardiac arrest. Diagnosis. Patient will have no central pulse and will be unconscious. You can listen and feel for breathing, whistle, observing chest movements. You place a hand on the patient's neck to feel the carotid pulse. Basic life support. Check area for danger, assess responsiveness, call for help, open the airway, check mouth for vomiting, debris and remove with finger sweeps. Assess breathing by observing chest movements and assess the carotid pulse up to 10 seconds. If no breath and no pulse is present, then perform 30 chest compressions of 4 to 5 cm each of the lower third of the sternum at a rate of 100 per minute, followed by 2 ventilations. If the pulse is restored, reassess breathing, and if satisfactory, then place the patient in the recovery position and administer oxygen. Steroid crisis. The use of corticosteroids therapeutically suppresses the adrenal response to stress, which in turn cause the patient to loss of consciousness. How to prevent? If patients have received steroids in the past years or in the steroids at present, cover any stressful procedure, anesthetic, infection or episode of trauma with 100 mg hydrocortisone IM 30 minutes prior to elective stress. Management. Place in supine position, maintain airway, give oxygen, obtain IV access up to 500 mg hydrocortisone IV immediately. Ensure help if requested. Exclude other causes of collapse. Anaphylactic reactions. An anaphylactic reaction starts a few minutes after a parenteral injection and not immediately. The drug most liable to present an emergency problem to the dentist are LAs. Symptoms: facial flushing, itching, numbness, cold extremities, nausea, and sometimes abdominal pain. The signs include wheezing, facial swelling, rash, and cold, clammy skin with thin, thready pulse, etc. Management: allow the patient to adopt the most comfortable position for breathing and give oxygen by face mask. The drugs are given in the following order: adrenaline, chlorpheniramine, hydrocortisone 100 to 200 mg IV or IM, intravenous fluids. Epilepsy: the majority of epileptic fits do not require active intervention as the patient will usually recover spontaneously. All that is needed is sensible positioning to prevent the patient from damaging himself. Fits may be precipitated in a known epileptic by starvation, flickering lights, certain drugs such as methotrexate, tricyclics, or alcoholism or menstruation. The signs include sudden loss of consciousness. Status epilepticus: if epileptic fit be repeated more than 5 minutes or having more than one seizure within a 5-minute period, the patient has entered the state of status epilepticus. This is an emergency and requires urgent control. Management includes IV lorazepam or IV diazepam. Beware respiratory depression, assess cardiorespiratory function, clear and maintain airway, and give O2 if available. Hypoglycemia: hypoglycemia is a diabetic emergency which may occur before the dentist. Diagnosis: disorientation, irritability, increasing drowsiness, excitability, or aggression in a known diabetic suggests hypoglycemia. Management: if conscious, give glucose orally in any available form. If unconscious, protect airway, place in recovery position, establish IV. Acute asthmatic attack: an acute asthmatic attack may be induced in a patient predisposed to bronchospasm by exposure to an allergen like infection, exercise, or anxiety. The signs and symptoms includes a complaint of tight chest and shortness of breath, breathlessness with widespread expiratory wheezing. Management include keep the patient upright, administer salbutamol, administer oxygen, give steroids. If a complete response takes place, it is reasonable to allow the patient to return home. If there is any doubt, arrange for the patients to be seen to the nearest emergency. Inhale foreign body: the combination of delicate instruments and the supine position of patients for many dental procedures inevitably results in the risk of a patient inhaling a foreign body. The first procedure is lower the airway. This presents as a less acute problem. Classically involves a tooth or tooth fragment slipping from the forceps or being inhaled. Arrange to have a chest radiograph taken as soon as possible. Rarely, lobectomy may be needed. Upper airway: this will stimulate cough reflex, which may be sufficient to clear the obstruction. A choking patient should be bent forward to avoid coughing. Conscious patient: support chest with one hand and strike between the scapulae with the heel of your other hand. Repeat up to 5 minutes. Unconscious patients: finger sweep to remove foreign body, abdominal thrust with victim supine. If all else fails, cricothyroid puncture may preserve life if obstruction lies above this level. Conclusion: prevention is always better than cure, so always be prepared. Prompt recognition and efficient management of a well prepared dental team that can increase the likelihood of a safe and satisfactory outcome. Reference: Medical Emergencies in Dental Office, Stanley F. Melamed, 6th edition, IDA Protocol for Medical Emergencies in Dental Office, Advanced Trauma Life Support, 10th edition. Thank you.